And warm greetings to all of you. I'm grateful to Dr. Maninder for inviting me for this webinar. And today I'm going to discuss regarding the blood cultures and PCR in the PICU, their interpretation as well as action. I'm Dr. Neha Gupta, infectious diseases specialist from the first batch of infectious diseases specialists in India, with close to 2 decades of experience across various hospitals, and I'm founder of NG Swastha, which is our infectious diseases clinic in Gurugram. I'm also secretary of SIDS India. So I'm going to describe the importance of blood cultures as well as the PCR with the help of this patient. Now, this is a 20-year-old boy. However, the principles which I'm going to discuss remain the same even for the pediatric population. So this is a 20-year-old boy who had no comorbidities and he's from Seedhi, Madhya Pradesh. On 20th of October, he was admitted with us in the ICU. He was admitted in shock. He had an AKI with the creatinine going up till 4, hepatitis, melena. He was febrile, and on NORAD he was maintaining his blood pressure, which was around 90 to 100 by 60, with tachycardia as well as tachypnea. He also had severe abdominal pain as well as tenderness on examination. His hemoglobin was 9.5. The TLC count showed leukocytosis, and there was a drop in the platelet count to 50,000. These were the LFT alterations. The serum LTH was 900, the CRP was very high, it was 391, the ferritin levels was close to 7,000, and the PCT was 7.75. Outside, he had received doxycycline for 2 days, was not responding much to this, and he had received 1 dose of ceftriaxone before starting from Satna, where he was admitted in the ICU, to Gurgaon with us. So when he arrived at around 4 o'clock a.m. In the emergency, after drawing the blood test, we empirically started on meropenem. Now the question here in front of us is, which of the following is the most impactful method for arriving at the diagnosis? Serology test, blood cultures, imaging including a CT scan abdomen or a PET-CT, colonoscopy, none of the above. So I will discuss each of these subsequently. So the patient was admitted with us on 20th of October, and from the emergency, the serological tests were also sent, and this included a Vidal, IgM dengue, and IgM leptospira, which was positive. The Vidal test subsequently came out to be negative. The Wheel Felix, which was also sent from the emergency, was negative. The blood cultures were negative as well. The CT scan abdomen, which was done on the day of admission, showed ileocecal thickening along with multiple lymph nodes, and they were large and necrotic lymph node. Along with this, there was a pleural effusion as well as mild ascites, and discussion with the radiologist mentioned that this could be TB as well. Now he was also having melena, so a sigmoidoscopy was done which showed that there were multiple blood clots which were traversing up till the middle part of the transverse colon. The further colonoscopy was not attempted because the patient was not tolerating it at that time. And now the correct answer is actually the detailed history taking skill. Why? Because when we look at all these tests, these looks very confusing. And when this patient had come to us, this in fact was the PET-CT, which was also done because he had large lymph nodes, and this was the ileocecal thickening and hepatomegaly. And since there was pleural effusion as well as ascites, even the radiologist was thinking that could this be tuberculosis. But what has made the difference is a detailed history taking. Now, with this patient's father, who's actually my Mamaji, he texted that his son is not well and he has been having fever for the last 5 days. They were initially thinking that this could be dengue fever because the WBC count was on the lower side, and he was also getting treatment from outside where he had received antibiotics, to which he was not responding. Now, with this history, we inquired further, and the history of fever, it's important to note what is the onset, duration, and the progression. So, it was an acute onset fever. It was high-grade fever right on day one with 104. Subsequently, 2 days later, he started having diarrhea, which were 12 to 16 episodes, watery loose motion suggestive of a small bowel diarrhea. And then he was admitted after 2 days in shock and AKI in Satna in Madhya Pradesh. Now, since there was this history of fever as well as diarrhea, we inquired further and they said that he had gone to Banaras just a day prior and he had eaten a dish which was transported from Bangalore. So it was a chocolate fudge transported from Bangalore, and it's the same night he started saying that I've started feeling feverish, and the next morning he developed very high grade fever. Since this history actually changed the entire game. And that is why this quote from Sir William Osler is very important, that we must always listen to our patients. It's the patient who is telling us the diagnosis. Now, with this history, as well as the onset of fever, as well as diarrhea, our differential diagnosis included that this is most probably a GI infection related to the contaminated food consumption. So the possibilities include Staphylococcus aureus enterotoxin, Bacillus cereus, non-typhoidal salmonella, enterohemorrhagic E. coli, uh, and the leptospirosis, but based on the incubation period, because it had started almost the same day, it is going in favor of Staph aureus, Bacillus cereus, or NTS. We normally think of Staphylococcus aureus enterotoxin or a Bacillus cereus enterotoxin. However, NTS is also one of the important causes of food contaminated food related diarrhea, which can go to sepsis. And in fact, here the blood cultures may not be always positive. Bacteremia may happen in 5% of the cases, but it can lead to severe sepsis, AKI, hepatic dysfunction, leukopenia, thrombocytopenia, and this is the most compatible. In fact, he had eaten chocolate fudge, which is egg, and that has NTS infection very commonly associated. So the history of food, which food the patient has taken or eaten, is very important. So based on this history, we had performed a biofire GI panel the same day when he was admitted, and this detected the salmonella. The blood cultures were negative for this patient, so this is not Salmonella typhi, but a non-typhoidal salmonella. And he received meropenem, to which he responded. Now, since we also had the evidence based from the BioFire GI panel, which is a multiplex PCR, azithromycin was added to this. We thought that we could de-escalate down to ceftriaxone, so that's why we de-escalated down to ceftriaxone, although the blood cultures were negative. But on ceftriaxone, the patient started having fever again, and also there were bloody stools which were seen. So that's why the patient was switched back from ceftriaxone to meropenem, and azithromycin was continued. And within 7 days, the patient was discharged. He was on meropenem for 10 days. And now, based on our knowledge that this patient is having acute GI infection with septic shock, which is related to the non-typhoidal salmonella, we started this patient initially on IV TMP SMX, and subsequently he was shifted to oral. Why? Because there was also extensive GI ulceration which had happened, so that would have hampered the absorption. That's why initially IV for 3 days, and then subsequently TMP SMX was given for 10 days. So a total duration of almost 3 weeks of therapy was given for a complete healing as well as for prevention of any relapse. So this appropriate history-taking skill, along with the right interpretation of the multiplex PCR, the blood cultures which were negative in this patient, as well as the serological test are negative Vidal, as well as false positive dengue IgM and false positive leptospira IgM, along with this multidisciplinary management of involving the radiologist, the critical care specialist, as well as the gastroenterologist, has resulted in early diagnosis, early start of appropriate antibiotics. It also avoided colonoscopy because that could have resulted in perforation in an acute setting. However, it can be done, but may result in complications. Avoided the bone marrow as well because there was a suspicion of lymphoma, but since we already had the diagnosis of salmonella from the biopsy GI panel, it avoided all these invasive investigations, and of course prevented complications. Had there been a little more delay, it might have resulted in perforation and a much more longer stay in the hospital, as well as all this would have resulted in a much higher healthcare cost. We also know that an infectious diseases involvement improves outcome in patients with severe infections, which includes all these syndromes, including septic shock, bone and joint infections, bacteremia, HIV-associated infections, endocarditis, and even complicated infections like this patient was presenting with fever, diarrhea, and shock. It's important when we draw the blood cultures that they should be drawn in the right volume. Timing really does not matter, it's the volume which matters. And when one bottle of blood culture is taken, in adults, we tend to take like 8 to 10 ml in one bottle of blood culture, but that will result in the isolation or the sensitivity will only be 10 to 15%. If we take one set, then the sensitivity of isolating the bacteria increases to 65%. And with two sets, it is almost 80%. And with three sets, it is 95%. So the same analogy also is aligned with the pediatric patients who are in the ICU. The volumes matter, and in fact, the blood culture has to be collected in the pediatric blood culture bottles, which are the green bottles. And usually, in the adults, it is the we collect 8 to 10 ml, whereas in the children, the volume is based on the weight of the child, and for patients who are weighing less than 40 kgs, no more than 1% of the patient's total blood volume, which is 70 ml per kg, needs to be collected. So at least in a patient who's 10 kg, so it will be 1% of the 70 ml per kg, that is 700 ml. So it will be 7 ml for a 10 kg patient, and 28 ml for a 40 kg patient should be collected for improving the chances of isolation of the bacteria. Now, besides the GI panel, there are several molecular assays which are well established based on the syndrome. So, identifying the clinical syndrome is important, and then we can perform the various assays, which includes for a CNS infection, a Filmare meningitis encephalitis panel. At the same time, this panel detects 14 most common pathogens which are responsible for the community-acquired meningitis, encephalitis, including viruses, bacteria, as well as the yeast. However, we must remember that it does not detect TB, which is very common in our country, rickettsiosis, Acinetobacter, which is a nosocomial pathogen, Enterococcus, cons, Japanese encephalitis, KFT, Nipah, as well as Cryptococcus. We also have the BCID panel, which can detect the 24 pathogens and uh, these 24 bacterial pathogens within 1 hour of the positive blood culture. Besides this, it can also detect the Candida species as well as the resistant mechanisms, including the MEC-A, VAN-A, VAN-B, as well as the 5 major carbapinamases. However, we must remember that bugs like Stenotrophomonas will not be detected by the BCID panel. So Stenotrophomonas, Burkholderia, Elizabeth may not be detected. We also have the BCID panel can detect Stenotrophomonas. However, it does not detect Burkholderia. So we have the URTI panel, which is also we have a URTI as well as a LRTI panel, and this can detect the various common pathogens which are responsible for the upper respiratory tract as well as for the lower respiratory tract infections. And as we have recently in this case described the importance of the Filmare gastrointestinal panel, which can detect the common pathogens, including parasites, bacteria, as well as the viruses. Now, it's important to know when to perform the molecular PCRs when there is a positive culture. So, traditionally, when we take the blood culture when we take the specimen and it grows in the culture, it may take around 48 to 72 hours to finally know that which antibiotic is going to work. However, there are certain tests which can be performed right when it beeps or becomes positive in the blood culture. And this is a table which helps us in analyzing the various diagnostic assays which can help us in detecting the carbapinamases like the NDM, OXA48, and can help the clinicians to choose the antibiotics for a patient who is in sepsis. So we have expert CARBA-R, which is a real-time multiplex PCR, and this can be performed from the positive culture plate or also from the positive blood culture bottle. So as soon as it beeps, so maybe even the first 24 hours, if the blood culture is positive, the expert CARBA-R can be performed, which is a turnaround time of 50 minutes. It can detect the 5 major carbapinamases, including the NDM, OXA48, or the co-production, and has a very good specificity of around 100%. It is around 3,500 to 5K depending from institute to institute. Then we have the Filmare BCID panel, which is a real-time multiplex PCR, and it detects the genes, the 5 major pathogens, along with the organism ID can also be detected. So whether it's a Enterobacteriaceae or it's a Acinetobacter, Pseudomonas, that can be detected from the BCID panel, and it can be done directly from the blood culture bottle, and the results are available to us within 1 hour. However, the limitation is the cost. We also have now certain multiplex lateral flow assays. These are immunochromatographic detection assays, which are non-nucleic acid based. That means it does not detect the gene. It can be performed from the positive growth plate, so not from the culture bottle. So it may take another additional 24 hours for the organism to grow on the culture plate. The advantage is that it can tell us just within 15 minutes the major carbapinamases. It has a very good sensitivity and specificity. The sensitivity may range somewhere around 90 to 95%. Now, based on the mechanism of resistance, whether it's OXA48, NDM, we can choose our antibiotics. So if it is an OXA48, then we can choose ceftazidime avibactam. However, if it is an NDM producer, then or an NDM with OXA48, then our treatment options are limited, and here we must perform synergy testing between ceftazidime avibactam and aztreonam through a broth microdilution method and not a disc diffusion method, because BMD is much more specific, whereas the disc diffusion may miss out, may give false negative synergy in close to 50 to 55% of the cases. If it is NDM, then we also have this aztreonam avibactam, which is available with us, and that can be used for the treatment of the NDM producing Enterobacteriaceae. Aztreonam avibactam may not really work for Pseudomonas, because with Pseudomonas, besides NDM, there are additional mechanisms of resistance which may compromise the activity of the Aztreonam avibactam. So how does this aztreonam avibactam work? Since it's a new molecule, it's important to understand the mechanism of action. Now we have the aztreonam, which is monobactam. It is stable to the NDMs. However, it gets hydrolyzed by the ESBL as well as the AMCs, which are present in the periplasmic space of the gram negatives. So what avibactam does is it protects the aztreonam against the beta-lactamases, ESBLs, and the AMCBLs, which are present in the periplasmic space, and thereby allows the aztreonam to cross the periplasmic space and bind to the PBP3, which is essential penicillin binding protein of the gram negatives present in the inner membrane. And this then inhibits the synthesis of the peptidoglycan layer, resulting in the bacterial cell lysis. So this is the mechanism of action, and it will work against the metallo-beta-lactamase producing Enterobacteriaceae, especially the Klebsiella pneumoniae, as well as E. coli. However, it may not have activity if there is PPP3 inserts for the E. coli. It has no activity against Acinetobacter baumannii, Listeria, gram positives, as well as anaerobes. So this we must keep in mind and give additional coverage based on the site of infection. And if a patient is on aztreonam avibactam and is having sepsis, then we must keep that there is a possibility of Acinetobacter baumannii as a superadded or a secondary infection. So the suggested workflow for a patient who is in sepsis, in the PICU, and is showing gram-negative bacilli is that identify based on the gram stain or with the availability of MALDI-TOF, the identification of the bacteria, and we can perform the assays, which includes the expert CARBAR, maybe BCID panel, or even the lateral flow assays. If the carbapenemase is not detected, then careful de-escalation of the antibiotic can be done. However, if it is carbapenem resistant, then based on the mechanism of resistance, we can choose the antibiotics. Like for OXA48, it is ceftazidime avibactam. For OXA48 with NDM or NDM, it is going to be aztreonam avibactam or Cazavi with aztreonam, or a polymyxin B combination therapy based on the various factors. And it's important that we should definitely involve a multidisciplinary collaboration, including infectious diseases consultation, send right investigations, including the blood cultures, which should be done prior to starting the antibiotics, which in fact is a very quick and cost-effective solution for patients who are arriving with fever as well as sepsis. It is all about the right test, the right patient, as done at the right time. And more importantly, we must always emphasize on infection control, because all these antibiotics, they're hanging by a thin thread which may snap any moment, and it's very important that we use them judiciously and with responsibility. And this is our initiative for creating awareness regarding infectious diseases in the community. Um,